We'll now move on to the next speaker. It's a pleasure to invite Dr. Suma Ganesh, who's head of the Pediatric Ophthalmology and Strabismus at the Shroff Charity Eye Hospital. Extensive experience in tackling pediatric ophthalmology disorders. And although she has expertise in a lot of areas, I actually requested her to talk on her vast experience in management of strabismus in children with CVI. Dr. Suma, please.
Thank you, Dr. Rohit, for the kind introduction. And also thank you. It is a real privilege to be here on the podium and with such great, all great strabismologists. I hope I am able to share something new. I would be talking on cerebral visual impairment, children with cerebral visual impairment and how to manage their strabismus. Is it moving forward?
No, it's not. Now it is. Yeah.
So what is cerebral visual impairment? Basically, there is a deficiency in the function of vision. Something is wrong with the visual pathways or the processing centers in the brain, specifically those posterior to the lateral geniculate body. So here the eye works fine. The brain does not consistently understand and interpret what the eye sees. So we do see a lot of children now coming because of the good neonatal care which is given to the children. And we do find them in the clinics frequenting us with problems of vision, of squinting, and also with refraction. So what is basically affected? It is basically the dorsal stream, which is connecting the occipital area with the posterior parietal cortex, and that is the where. And also the ventral stream, which connects the occipital and temporal lobe territories and tells us about the what. So unique characteristics are, of course, the light gazing or non-purposeful gazes. So especially in the OPD, when we see that the vision is not collaborating with the age, we need to further investigate them. The other visual preferences behaviors are basically the field defects which we see. Most of them, they have an inferior field defect. So it is important to test with the simple help of the toys to check which visual field is affected to help the rehabilitation expert. And also other characteristics are the visual latency. You have the child is very slow at looking at the object, and there are difficulties in viewing in a complex environment and difficulties in distance viewing. There is a color preference. Red and yellow may be the most commonly preferred colors, and it is important that we tell the visual rehabilitator what the child is attracted to and which color the child prefers. So the vision assessment is done we do it with the help of the TAC or with the LIA pedals if the vision is very poor. So we know that the LIA pedals, if the age of a child in months is equals to the breathing in the cycles per degree in the LIA pedals. So we can measure the vision in these children, and the LIA pedals helps us unilaterally and binocularly to tell us how much is the visual acuity in the child. It's also important for the visual rehabilitator to tell them about the contrast sensitivity. So we can use the hiding Heidi and tell them whether there's a 10% loss, 25% loss, or 100% loss. And this will help them to rehabilitate the child because they know that the contrast is also decreased in the children. Cycloplegic refraction, of course, cyclopentolate should not be used. Mainly it is atropine. And we need to correct the refractive errors before going in for any strabismus surgery, because we find that these children, even with small amount of hypermetropia and astigmatic glasses, they commonly do very well. It's also important to assess the accommodation in these children because most of them have the lag of accommodation, and we need to give more air in these children so that they can accommodate and they can be able to see better. So a dynamic retinoscopy is very, very important to check for the lag of accommodation. And this is how we document it, that we say the serious, like in this case where there is a left gaze paresis that the child prefers to the right gaze, and there is light gazing, non-purposeful gaze, and difficulty with all vision, like the visual latency is a problem. So all this if we document, and this could help the rehabilitation expert. So in the OPD, how to differentiate between an OVI and a CVI, where we find that the vision is not accountable for, has the other parameters are normal. We need to do a simple LIA puzzle where we find that the child has difficulty in orienting the objects. There's difficulty in eye-hand coordination. This is called as optic ataxia. This is the impaired visual guidance of movement. And this tells us there is small amount of brain damage. We can also use a Lear mailbox. Like here, the child is able to drop the card through the slot of the Lear mailbox. This is a small thing. And this is the child is able to demonstrate the orientation of the slot by turning the card in the correct position. And here we find that in a CVI child, the child is not able to orient the spot correctly. So this tells us that there is a small, that this child requires further help by the special educator and the other, and also with the help of the occupational therapist. So other neuro-ophthalmic findings are basically, we find there's a hypoplastic or large disc, and it is important to differentiate them because most of the time these are children identified as glaucomas. Of course, we need to do MRI in these children. So the strabismus is found to be as high as 73% in these patients. Esotropia is most common type of strabismus, and exotropia is also seen. The problem is the angle variability and the shifting patterns. And so we need to do stable, we need to repeatedly measure them and then only plan them for surgery. In periventricular leukomalacia, we found that there is esotropia and exotropia and other varieties of strabismus also. We need to look for them and we need to perform the surgery. In our paper published, we found that exotropia was seen more common than esotropia, the major cause being perinatal hypoxia. In another paper where we published, we found that our motor evaluation revealed strabismus in 67.04% patients, and most of it was exotropia. We also had associated dissociative vertical deviation, and the mean angle of deviation was around 30 prisms for both ESO and exotropia. There could be spontaneous resolution. That's why we need to have 4 stable measurements. Do not operate them if they have poor visual behavior or they have unstable deviation or a shifting pattern. Measure at least four different stable measurements. So this is a child with having similar problems, like this looks like an esotropia case, but there is problem in focusing, inward deviation. It is a premature baby with a delayed milestones and with a right side hemiplegia. Did a atropine refraction, found that there was no significant refractive error, performed the surgery, and the child did well. But the important point is after the surgery, the child does require the role of vision rehabilitation and vision therapy. We may need to use the PEG board or to improve the saccades and also the other therapies to improve the coordination. So we can see that after the surgery and before the surgery and after surgery, how the handwriting of the child has improved. And we find that in children with CVI, the learning difficulty is much more, and strabismus is reported to be there, which is partly responsible for the learning difficulty, and therefore we need to operate them as early as possible. We found that there was a published literature on long-term results of esotropia surgery. We did our own study comparing our results with children with infantile esotropia with neurological impairment compared to normal children. In most of our cases, there was HIE. We found that our success rate was 61.23% in the neurological group with a follow-up of 23.313 months. We compared our study with the study done at Shankar Nethralaya, and we found that the results were comparable. But the sensory results we found that was not very gratifying. So it was a really major challenge. It was a realistic goal if we could achieve some amount of sensory fusion in these children. So what we also found that some of these children went into consecutive exotropia. So there's an exaggerated effect of the bilateral medial rectus recession in these children. We need to undercorrect them by around 30%. That's what the review of literature showed. So like these children who were operated earlier, they went into consecutive exotropia over a period of time. And for them, we had to do a medial rectus advancement or a recession surgery. So it's important that we follow up these children. Like there's another child who was referred by a psychologist to me saying that I have treated this child for attention disorder. And her child also had a CVI with an attention deficit. And the child was not able to write or falls down frequently with vision of only 6/18 with exotropia. Performed the surgery, and the psychologist informed me that the social maturity scale, which he found the social quotient had improved after surgery. The developmental profile also, which he measured after surgery, improved, and also the attention problems. So this makes us more and more, and it allows us to say that we need to operate these children and not say that these children may not improve with surgery. They have problems in visual perceptual skills and maybe having dyspraxia, so they may be associated with DVD. And it is important that we tackle them as a routine, as a strabismus surgery, which we do for an exotropia with DVD, and we do get good results. There may be mixed deviations, and so the results are very gratifying. We find that there is improvement in communication, improvement in cognition skills. The child starts walking, the child starts going to school. We find there's an improvement in the, we could make these children go into integrated schools with the help of a special educator, and make the child perform very well. So this is we know that CVI is a spectrum of disability. We find that a lot of issues are there, but of course, with multidisciplinary services and with a combined approach, we can definitely help these children. Thank you.